One more thing I learned is that there's no magic bullet solution to improving these, procedural outcomes. If we're going to do this, we're going to have to use like a multimodal approach to improving first pass success and improving airway quality. Um, that might be, bougie and VL as first attempt approaches. That might be, improved education, improved simulation. But it's going to have to be like multimodal, and there's no free lunch when it comes to this stuff.
But I believe the systematic review about head injuries and intubation in the pre-hospital setting, I forget what year it came out or who the authors were. But like you said, I think they recommended it. Like if you can get it on the first try, patients tend to do better.
Yeah, well, so much treating these brain injured patients in the pre-hospital setting is, um, mitigating those second injuries or like the second like factors like hypoxia, hypercarbia, hypotension. So if we have a patient that's so ill that we're not able to oxygenate them and manage their CO2 without a tube, then obviously doing that's going to be beneficial. And then, the added benefit of an endotracheal tube compared to something like an SGA is that we can then like sedate with DAS and fentanyl and stuff like that, which can help mitigate rises in ICP, right?
And that's not a prescriptive approach to say like all head injury patients should be intubated because oxygenation is key. And I know we've spoken about this before, but what are signs that we should intubate? Because I think we're remiss in the education training. It's like, we have this tool now, but you should know when to intubate and when to do an SGA or a BDL. Like, what are telltale signs that we should intubate this patient?
There's been so many changes kind of in the past several years in terms of like recommendations for this stuff, right? With SGAs becoming the first line approach for airway management for most critically ill patients and definitely cardiac arrest patients, right? Like if you have a patient with a medical VSA, an SGA is what they should be getting, especially after like the Airways trials and things like that, right? And even for pediatrics, they've shown that like SGAs have higher first pass success and similar neurological outcomes, similar ROS rates, similar kind of everything, right? That we care about, and especially what patients care about. However, there's obviously those cases where there's severe airway, like soiling and things like that, where an SGA is not the right option. Could trauma patient with a skull fracture if they've got a bunch of blood in their airway, a patient with a variceal bleed, like esophageal varices bleed. Any of those like severely soiled airways, and intubation is definitely going to be preferred, especially since you can then provide, um, deep suctioning and things like that. And obviously like critically ill patients that require advanced aggressive airway management will benefit from an ATT compared to an SGA because we can then like provide sedation and or deep suction and things like that. So, having that actually definitive airway early can be beneficial for a certain cohort of patients. However, I can't just like give you a list of those exact cases. That's why we're going to be, this is a clinician thing. You look at your patient, you think about your transport time, you think about your resources, everything.
Correct me if I'm wrong. In the paper, you discussed how intubating on the scene is different than intubating in the back of the ambulance.
Yeah, absolutely. So I think it was Orange that discusses like in their airway programs, they discuss like the hierarchy of intubation positions or locations. And so like on scene on the ground is kind of like a mid-range. It's a decent place to intubate because you have space, you have all these things, you have a partner. However, in the back of the ambulance, when it's parked, is actually the best place you can perform intubation because they're on your stretcher, so you can get more of an alignment. You can position your patient more optimally. You have your wall suction for your solid technique. You have your wall mounted M tank for your oxygenation that you're not going to run out of. And also like your partner's still there because you're parked. And then in the back of the ambulance on the road is the worst place you can try and intubate because, obviously resource limitations, and the movement is going to dramatically complicate your procedure. So.
Another anecdote, I'm sure you experienced too. Like imagine transporting, you're trying to intubate, so you're already up in an uphill battle. And if you're doing CPR, someone's doing CPR, like a bump or just by their location, their elbow is hitting the laryngoscope. And you're like, this is incredibly difficult. to try to do this
Absolutely.
procedure.
Yeah.
So these are the barriers we're facing in the pre-hospital setting.
Hmm.
I'm curious, in your review of the literature, did you find like a number for the pre-hospital setting where it specifies you need at least 80% of intubations to be successful on the first pass success rate to meet like patient safety metrics?
Yeah. So it's kind of poorly defined. So the ILCOR guidelines recommend that services with a low overall success don't intubate, and services with a high overall success do intubate. However, they don't define that. But the European Resuscitation Council does define that. A service with a over 95% overall success rate would be a high performer, a high performance service. Obviously, there's a lot of room for improvement for most services in Ontario to reach that number. Most are probably around the 60 to 70 mark. So
This is where your work's coming in.
hopefully we can develop a good suite of interventions together and increase that number.
So is that the goal of all this?
Absolutely. Yeah.
So to figure out what's the contributing factors of maybe a not ideal first pass success rate, then tailoring your approach to training and change guidelines and practice in Ontario.
Absolutely. And, inform education as well. Right. So, I think that's probably the biggest lever that we can use right now is high quality education and simulation training. And, there's evidence showing that significantly improved first pass success and it was sustained over a year. I think that was done with like the AIM course. So like a service put their paramedics through the AIM course and they increased their first pass success by like 20% or something like that. It was sustained over a year. So there's tons of levers that we can pull. Education is definitely huge, but then there's these kind of systems and equipment factors that we can also use.
What did the training actually look like? Like, what was their paradigm to make that such significant changes?
Yeah, so this was actually just like pretty simple and comparable to our CMEs that we offer, right? They did a 10-hour in-person course where paramedics were taught by expert educators on various area management techniques with a lot of like emphasis on hands-on training. So they did like simulation with soiled airways, pediatrics, like tons of different mannequins and things like that. And then they were able to show that they increased their first pass success by 7% over a 12-month period, which was statistically significant. So that's one lever that we can use for sure.
So to make sure I get this correct, for one 10-hour session, they improved their first pass success rate that was sustained over a year.
Yes.
Very interesting.
Yeah. With like statistical significance, this isn't just like a percentage. So it remain that way. So if you think about like, okay, maybe we can increase our first pass success by 5% with VL, maybe like another 7% with Bougie, maybe another 7% with a really high quality course. These are things that we can all start doing together as a constellation. That could maybe get us to the point where we're considered like high performance.
Where's that study done? Sorry.
This was out east, I believe. Like that's where the AIM course is set up. It was done by Carter et al. In 2022. So pretty recent as well.
And how did they define like an airway expert? Like was that
I think
RTs or anesthesiologists, critical care paramedics?
most of the educators in this program are like ED dogs, my understanding.
And like how high fidelity were the mannequins and equipment they used?
So my understanding is they use like pretty standard airway management equipment. They also use like solid mannequins, like mannequins that can vomit while you're performing intubation. That are more like closely mimic the real circumstances might be present in the skill wounds.
Incredible. So where do you think the future is with simulation and airway management? Like where could we go?
Yeah, the way that I would see this going is a requirement for ACPs. Obviously, when you put in requirements, we need to put in systems level changes that allow paramedics to fulfill those requirements. Would it be a requirement for a certain number, probably around like 20 high fidelity simulated intubations per year on like a variety of patient cases and ages in order to like maintain competence? I think that's where I'd like to go with the education and kind of maintaining skill sets.
I know this statement comes up a fair bit. I'd love to know your perspective on it. That in the perfect world, it would be so nice if paramedics can go back to the OR to get the skills, get the reps in, pick the professionals' brains. But I believe these studies have been done and doesn't necessarily translate to what we do. Because again, we don't do it in RSI, we don't do it in the operating room. So, and the research shows that high fidelity simulation can be alternative to real life experience in the pre-hospital setting. Do you think that's just a good equalizer that if we can't go to the OR because of space, because of resources, and maybe there isn't that empirical benefit, that we could implement the simulation to improve first pass success rate?
Absolutely. I think just the return on investment, right? Because as you talked about for VL and stuff like that, there's a financial responsibility there. And sending every ACP to the OR once a year would be great. I'm sure people would love doing it. They probably feel really confident coming out of there. But as you said, the evidence is not necessarily there that would lead to sustained improvements, especially compared to, these training days with high fidelity mannequins have shown to lead to sustained improvements in first pass success and intubation quality. So I think simulation, like high fidelity simulation, um, like every CME or dispersed throughout the year is absolutely a very valid approach we should look into.
Are you aware of any services around the world that have the best first pass success rate?
Yeah. So the one that I used to compare was in the UK, and they're actually doing intubation with no drugs, similar to us, right? So they're drug-free tracheal intubation. And they were able to get an overall success rate of like 96%. Be like specialist paramedics. Um, so I think, that's a very good goal to kind of aim for because they do have the similar like limitations to us, right? In terms of scope of practice.
So how do they get there?
I mean, there's like just so many differences in terms of their education and training and ongoing training. Like these specialist paramedics have access to OR time. They have access to a lot more like CME time and things like that. So and also their exposure to intubation because of like their um, tiered response and specialized response to incidents. Their exposure is going to be a lot higher than most Ontario ACPs. So there's a lot of factors that kind of go in there.
And that's hard to generalize here because even if they don't use drugs like we do, they have different logistics and avenues to go down.
Absolutely.
So to wrap this all up, what are the most significant lessons you learned throughout your research journey looking at OLAs?
And honestly, I think the number one thing I learned is that there's no magic bullet solution to improving these procedural outcomes. If we're going to do this, we're going to have to use like a multimodal approach to improving first pass success and improving airway quality. So that might be bougie and VL as first attempt approaches. That might be improved education, improved simulation. But it's going to have to be like multimodal, and there's no free lunch when it comes to this stuff.
For significant and lasting improvement, what could we do?
So we really need to build like a system of practice around it, right? So from a base hospital perspective, it's, maybe having clinical practice recommendations for services like you should have bougies available for your ACPs to use on intubation. We should be recommending that they do this, like actually making more clear and concise recommendations for practice, I think, be reasonable. And if the evidence does support it, then maybe making a recommendation that, ACPs have access to VL as well, like making that a priority if the evidence shows that that's what we should be doing. And then from like that simulation and education standpoint, having like a refresh of intubation and airway management at like probably every CME, because it's still just twice a year, would be a really good idea just to make sure that people are getting hands-on on this stuff at least twice a year. And then what we're working on doing at the RPPO is setting up a elective CME day, which is like that 8 to 10 hour day in person, practicing intubation, things and stuff like that.
What's been the most enriching experience of all this research you've been doing?
I'd say it's given me like a better, broader perspective on the complexities of actually leading or achieving improvements in paramedicine or prehospital care or medicine in general, right? Because it's the outcomes that we look for are so multifactorial that you can't just like look at one thing, say it's better, and then just switch to it and expect to have really good results. And that goes for like all of emergency medicine.
We need more people like you, Jacob. You're making waves in this profession. And once again, I commend you for doing this research to improve patient outcomes. Is there anything you want to leave the listeners? A couple last thoughts?
I think that if we want to continue advancing our profession and increasing scopes of practice or increasing the things that we can offer for our patients, we're all going to have to take it into our own hands to a degree. And whatever opportunities you have to like improve your skill set, improve your yeah, your first pass success, all these things, we should be doing it as individuals as well.
Thank you so much, Jacob. Can't wait to hear where the results lead and how this could change the profession potentially.
Thanks a lot, Ryan.